Hey friends, welcome back. I have the amazing Dr. Lisa Larkin with me, and she just told me I'm not allowed to read her bio. So, so welcome, Dr. Lisa Larkin. Who are you?
Thank, thank you so much, Kelly. So fun to be here. So I'm a women's health internist in Cincinnati, Ohio. I'm founder of a company called Ms. Medicine. I also have a multi-specialty women's health and consultative practice that I still work in. And just a couple weeks ago, I was inducted to be the president of the Menopause Society, formerly the North American Menopause Society. We just rebranded as the Menopause Society earlier this year.
I love it. Thank you so much for coming on. Dude,
Thank you.
so why did we, like, jumping in the middle of this conversation, why did NAMS, because all the people who say NAMS
Yeah.
say NAMS, why did
Yes.
NAMS rebrand to the Menopause Society and help for all of it? Do we get forgiven if we still call it NAMS because it rolls off the tongue nice?
Yes,
Okay.
absolutely. I can tell you this was something that a lot of thought was put into. Menopause, you can kind of say now is having a moment. Certainly, I've been involved in this organization for since 2000, so for a long time now. And despite being involved in this organization and really caring about this space for a long time, there hadn't been a lot of interest, until the last few years. And so in the last year, especially, our organization has grown tremendously. And in looking at not just that post COVID change in the way that everyone's practicing medicine a little bit, an infusion of money into the femtech space, lots of companies working in this space, and lots of growth in our membership and interest in the space, it really was time to kind of rebrand, retake a look at what our website is doing, what we are doing as an organization, refocus on what our mission as an organization really is. And I'm just very excited with the whole rebranding, and really excited to have the website launch, which should launch sometime in January. So we're very close. We've been working hard on that. So lots of good stuff going on in the organization.
That's going to be great. What I love about you already is that you're so much menopause is kind of pigeonholed into OB-GYN, right?
Right.
And I think it's very unique to have an internal medicine voice. I'm not an OB-GYN, I'm a urologist, right? Like I'm part of the OG female urologists that are kind of taking on female sexual health and
Yes.
hormones.
Yes.
And so to me, I'm like, we need these voices because we can't pigeonhole women's health into the OB-GYNs. They're already
Right.
busy. There's not
Right.
enough of them.
Right.
So
Well, so I like to describe my professional story as I've always been a square peg in the round hole. So I've had a non-traditional 32-year career in medicine, but I can tell you that you're exactly right. Like my whole thing for being my presidency this year for the Menopause Society is really to bring more primary care into the Menopause Society. So we are a very multidisciplinary organization, but still it's heavily OBGYN. So it's about 65, 68% OBGYN, 20% primary care, and a smattering of other specialties. But to your point, I mean, this is my whole professional journey, which is women's health does not belong to any one specialty. Women's health, sex specific medicine happens across the lifespan for women. And yes, the OBGYNs play a critical role in women's health, but women's health is much more than bikini medicine or reproductive organs, right? And as women age and get beyond their reproductive years, they have sex specific health issues. And if we don't engage primary care, because the number of primary care, internal medicine, family medicine physicians across the US is 10 times the number of OBGYNs, we need to have them engaged in women's health, menopause, high risk breast, sexual medicine, women and heart disease, all of these other things, and work collaboratively with our OBGYN partners to provide comprehensive women's health care across the lifespan, because really one specialty just can't own it. And so It's one of the reasons that I've loved the Menopause Society all these years, is because it is multidisciplinary. And again, because as the internist, even though I'm a square peg in a round hole all the time, right, I really have a place here. I really can offer a different perspective. And I think now that menopause is having a moment, this really is the time to engage more primary care doctors in this space, because the only way we're going to make a real impact and change things is if we have, again, partnership between OBGYNs and primary care and urologists, to your point, where we're all working together, as opposed to the way our health system is currently set up to have us in silos, because that just doesn't work for good women's healthcare.
Yeah. Yeah, absolutely. I don't want to assume, but I'm assuming you did not get trained in menopause during your training, and
I didn't, and that's the exact story, right? So I finished residency. I actually was going to do pulmonary critical care, but for lots of personal reasons ended up not doing pulmonary critical care, and came to Cincinnati in 1991 and joined the faculty post-residency. And immediately, as a female internist, women were gravitating to me, female faculty members, and it was crystal clear in 1991 that no one was addressing menopause in the way that was happening, right? We had some data from the Nurses' Health Study then about hormones, and we were using hormones, but not great data. And kind of things. I say that my entire professional career has been defined by the journey of hormone therapy and our learning from 1990, when we had just the observational studies, all the way through the WHI, and to where we are with understanding the WHI now, right? And it's been this really interesting journey. But for me, as the female internist in an academic faculty, it really behooved me to become trained in menopause, osteoporosis. I started doing got really involved in the women's health space as the internist, because there was a need for my patients.
Mm-hmm. Yeah. At what point did you realize, because I have to think, your pulse has been on this before so many people now. Like, I think people are just waking up to what the WHI has done and how it kind of silenced the conversation about hormones. When did you start realizing the WHI wasn't going to be applicable to everybody, and maybe was too broad of a brush?
I think early, and again, I'm old. Remember, I'm old compared to you, right? So, my story is, I left academics for the first time. I've been back in academics twice, but left academics for the first time in April, just before the WHI data broke in 2002. And I had just launched my own private practice at that point. But I was known in my small Cincinnati community as someone who was doing women's health already. And so that data broke in the way that it broke. And I think those of us in the space, I know Mary Jean Minkin talks about this a lot, which is like, we all remember where we were at the time the data broke, right? Because it was a really big deal. And again, the way that it was presented in the media, we knew from the beginning was the wrong way to be presenting the data, right? Because again, throwing out the numbers of it, and I could tell you exactly what happened then, 25% increased risk of breast cancer. And every single woman took that to mean, I've been taking hormones, and it means that I have a 1 in 4 chance of developing breast cancer. And every woman in the United States virtually stopped their hormone therapy immediately. Dr. Udian in the Menopause Society used to say that, it was the time in the U.S. when the most rivers and streams were polluted with estrogen, right? Because it was all being dumped down in the toilet. But very early, we knew that the data was never intended to look at our menopausal patients around the transition, right? This was really designed to be a very different study. So until we actually, over time, learned to risk or stratify the data based on age and really start to look at it differently, that's where we are today, with a very clear understanding of who's a good candidate for hormone therapy and who's not such a good candidate for hormone therapy. And we've learned a tremendous amount since the WHI, but even right in the beginning, I was someone that was out there that was really trying to quiet the storm and kind of reassure people a little bit, not to not understand the data. But you probably know that that was the time when the whole bioidentical hormone situation took off, because there was room in the market. All these women who had stopped taking their hormones suddenly were having hot flashes again. And the women who were entering menopause were miserable too. No one knew where to turn. And my internal medicine colleagues stopped prescribing hormones. stopped and honestly, I just had a patient recently, which is hard for me to imagine, came to me for a consult and had just seen her primary care doctor, who specifically said to her, our practice is a hormone-free zone. That was the statement. So this is 2023, right? So the impact of the WHI can't be overstated.
Yeah, it's really in the ether, right? Like there's fear in the ether. People don't even know where the fear came from. Physicians we have 2 decades of physicians that didn't get trained because of the WHI, and so really starting back in the residency programs and the med schools, like this is literally we have to change the deeply embedded fear that this study did.
Right. And I'm not sure, frankly, that the majority of internists that are my age that have been practicing with me, I'm not sure that we have a hope of converting them to becoming comfortable with hormones. And in fact, with the approval of the new non-hormonal that's out, I've participated in some advisory board meetings with other primary care doctors. And the fascinating thing is, I've heard them say, oh, thank goodness, now I will never have to talk to my patients about hormones again, right? And that
Yep.
I've really been very clear in my messaging that that's not what we should be saying still. But again, I think that certain age group of clinicians, my age group, right, who've been practicing for a long time, who've lived with the WHI data, not really understood it, have just said, I'm a hormone-free zone. I'm not sure that we can rectify that.
Yeah. Let's talk about the non-hormonal options. So we were talking about the Super Bowl ad. It's an oral medication. I'm going to try to pronounce the generic. Bear with me. You can probably say it better than me. Fezolinitant.
Fezolinitant, right. Veoza is the
I'm so glad
name.
I went to
That's
med
right.
school so I can podcast well and say the names of drugs.
Yeah.
Okay, Fezolinitant.
I'm a terrible linguist, so I mess up pronunciation of everything all the time.
And this works centrally on the brain to basically dampen down hot flashes. Am I getting that right?
Yes. So,
Okay.
I love internal medicine because I love the science. That's one of the things. And I use the analogy now that where we're starting to understand vasomotor symptoms and what has led to this drug development is really, really exciting basic science research, in the same way that recent research in the migraine space has led to incredible development of targeted therapies that are highly effective in the migraine space. And the same thing, for years, decades, we've really kind of just used the analogy or not really understood vasomotor symptoms, hot flashes and night sweats, just thinking they're all related to estrogen deficiency, right? So we definitely know that estrogen has a role. But the truth is, this, not all women all women go through menopause if they live long enough, but not all women have hot flashes, and certainly not all women have the same degree of hot flashes, but all women have low levels of estradiol. And so what's actually different? We actually really needed to have some good basic science research to understand that it has to do with neurons in the hypothalamus and signaling that has to relate to estrogen. So in the absence of estrogen, through these things called candy neurons, they over-signal into the hypothalamus, and this causes a narrowing of kind of the temperature regulation zone. And in the presence of estrogen, that temperature zone is widened. So you can't moderate your temperature very well when you're a menopausal woman, right? Small swings in ambient temperature cause you to have a hot flash, and then you chill, right? And so now this new medication actually binds in the candy neuron to prevent that hyper signaling into the hypothalamus. And so again, it's because we finally figured out these candy neurons, we kind of have a better understanding of the pathophysiology. It led to this targeted therapy, which I think is a really big advancement in the space, and very excited about having another option for those women who are not good candidates for hormones or can't take hormones for specific contraindications.
Wonderful. But my big question is, so I've seen the data that having hot flashes, severity of hot flashes correlated with cardiovascular disease, cardiovascular risk.
Right.
Do we have data to say if we treat those hot flashes either with estrogen or with fezolinitant, that we're changing the trajectory of that heart disease pathway?
So
And
we would like to have that data. And the simple answer is for menopausal hormone therapy, we have some data, right? About early initiation of hormone therapy around the time of menopause showing reduction in cardiovascular endpoints, right? MACE endpoints. And we don't have that data for fezolinitant at all. And of course, we wish that we did, right? But I think that again, although we've made huge progress in understanding the pathophysiology, I don't think we have it all figured out yet at all, right? So the other place where we're looking at these medications is, right, we know that hormone therapy at the menopause transition can positively impact sleep, can sometimes positively impact mood, right, very clearly, and cognitive functioning, that brain fog, right? And we know that there's some association with people who have very severe vasomotor symptoms and cognitive dysfunction, right? And so the question, of course, is if we treat hot flashes a different way with something that's not estrogen, do we have the same results? And we just don't have data yet. I can tell you that the companies who are developing these things would love to have data, but I think that's one of the important reasons to remember. And when I was on these advisory boards with my fellow internal medicine colleagues, right, I really caution them that don't throw the baby out with the bathwater, which is that menopausal hormone therapy has benefit for women to a large extent. We should be using it in the right patient for the right indication. And fezolinitant is a great addition, but in my opinion, it doesn't replace menopausal hormone therapy for the vast majority of women.
Oh, I'm so glad I have an internal medicine brain on right now because you are the one who can actually answer these questions. Because to me, I'm like, is it a hot flash Band-Aid? Meaning it's going to make your hot flashes better, but it's not going to change the trajectory of that heart disease
that's right. I mean,
all
so
the other
you
things.
probably know, and I forgot you weren't at the menopause this year, but there's a lot of, science being done. We don't have it clearly figured out yet, but the hot flash, there's other things related to that, right? So there's inflammatory markers that change. We see increased fat deposition around the heart, right? More aggressively in women who are having more severe vasomotor symptoms. We know that there's autonomic dysregulation that occurs as well. And I don't think that there's any data that the fezolinitant Veoza is going to impact those things yet, right? Mm-hmm. I think one of the first things that everybody's looking at is because it's a centrally acting agent, how does it impact sleep, right? Because that is the other big thing that women really struggle with these nighttime hot flashes. And so again, I think we're looking at all of these things as it relates to data. The other thing is interesting is that in the trials that led to approval for fezolinitant, there were no breast cancer survivors, right? So we don't even really have data. It's not a hormonal medication, but we can't specifically say that it was studied in that population. I can tell you that it wasn't studied in that population, but understanding the mechanism of action and the fact that it's non-hormonal, I think that that's a great place to use fezolinitant, and certainly I am using it in that patient population. But again, we don't have as much data with this medication yet as we would like, and that goes back to we have a lot of data when it comes to hormone therapy, and it's not all bad data. We should be using hormone therapy still. But again, I think it's your generation of younger clinicians who are going to move the tide here and really start afresh with using hormones appropriately in the right patient population as we go forward.
Yeah, absolutely. One of your favorite things to talk about is breast cancer risk assessment and prevention. Can you talk about like your story, what you do as far as advocacy now? I think people are going to be very interested in that.
Yeah. So, as I said, I've been doing menopause and women's health for a long time, my entire professional career, really. But I became a breast cancer patient and a breast cancer survivor in 2014. So I'm just at 9 years now. And again, probably for you weren't really, I don't know what year you actually started practicing yet, but I can tell you that in 2012, 2013, when I was attending meetings, professional meetings, in fact, we were just learning about 3D mammography and the benefit of 3D compared to 2D in women with dense breasts. And in fact, it's a funny story, which is the November before my diagnosis, I had gone out to Hoag Hospital to work with a guy by the name of Gary Levine, who was one of the pioneers in the 3D mammography space. And when I was out there with him, I knew I had dense breasts, but this was just early in this. And I said to him, hey, I have dense breasts. You should probably do a 3D on me. And he's like, oh, if you want to, jump on the machine. And I was like, oh, I just had my mammogram in June. Like, I'm okay. I'll do it when I am back in Cincinnati. And fast forward, then, I'm diagnosed in March, right after that, right? So just 9 months after my mammogram, and clearly would have seen it at that point on the 3D. But again, I tell the story because this is just the beginning when really we were starting to learn about the impact of breast density, not just on what we always thought, which is decreasing the sensitivity of mammography, but also on being actually associated with an increased risk of developing breast cancer. And that's where really more and more work has gone into now, which, I talked about and did a lecture at the menopause meeting this year and speak about quite regularly, is that we have to do more to identify women who are at risk of developing breast cancer. Because right now, our screening guidelines for doing mammography are one size fits all. They're age-based, they're not risk-based at all. They don't take into consideration anything else. And so I use the analogy of what we're doing with mammography is screening for cancer that's already there. Right? And it's very important to do mammography. We need to detect cancer early. We know that earlier detection, smaller tumors have better survival, but the cancer's already there. It would be much better if we focused on cancer prevention, which we don't talk to women about enough yet. And also the other thing is to identify those women who are at high risk, very high risk, because we should be screening them differently. And P.S., we should be talking to them about medications to reduce their risk and lifestyle things to reduce their risk. And we should be doing better to find mutation carriers. And the fact is, we're just doing a terrible job. The data really shows we're doing a terrible job. But there's tools available to do this, right? So I use the analogy, and again, this is my internal medicine background, right? If we were approaching cardiovascular disease the same way we approach breast cancer right now, is we would just be telling all of our patients to get an annual stress test. Just get the stress test and just wait till it's abnormal to know that you have heart disease. Well, that's not what we do. We really focus on identifying patients who have risk factors, and then we really work on modifying those risk factors to reduce the likelihood that they develop heart disease. And we need to be doing a better job of that with women. And so, my whole passion is really to educate women that when we talk about this statistic 1 in 8 or a 12% lifetime risk, that's population. That has nothing to do with what you as the individual woman, what your risk of developing breast cancer is. It could be lower than that. It could be higher than that. And there's all kinds of factors that contribute. And women still today, don't really recognize the impact of lifestyle on breast cancer risk. They aren't, again, this is where midlife women fall through the cracks. They don't have a lot of points of contact with the healthcare system between 40 and 60. Doctors don't know how to do these risk assessments. Women don't really, they know they have dense breasts, so that really to them still, in terms of, they don't correlate that with actually how much that increases their risk. It's like telling someone they have blue eyes, like, you have dense breasts, you have blue eyes. Like, what do you do with that information? And frankly, doctors don't really know what to do with that information largely yet, right? Mm-hmm. And so this is just a big move. And I think at the menopause meeting, one of the exciting things for me personally in both the Medical Breast 101 course, as well as the Precision Oncology for Midlife Women session that I did as the first part of the meeting, was really the incredible advances that we're making, both in risk assessment models, but in using artificial intelligence and data from mammograms to learn more about breast composition and other things that we can actually see now, which the future is very bright in terms of us now being able to move towards a risk-based screening protocol for women, where we actually help them identify their risk, and then we do things differently depending on low risk, medium risk, high risk, right? Which is what we should be doing, and more of an emphasis on prevention for women.
Yeah, all I ever hear is like, I'm at high risk because I have a family member with breast cancer. And to me, I'm like, that's not really dialing it down. Like, so much, correct me if I'm wrong, but so much breast cancer is either just de novo or because of lifestyle. And it's not really that family member that like gives you the risk or doesn't give you the risk.
Right. So the majority of women who, and I had no family history, right? The majority of women who develop breast cancer don't. And you're right, that's kind of the misnomer. Now, family history is very important because we're missing all these hereditary cancer mutation carriers too, because again, as primary care in a busy practice, seeing 28 patients a day, family history gets neglected. The medical assistant who checks the patient in may look at it, but the doctor is managing diabetes and hypertension and ignores the family history. And so we just have such opportunity to do better care for women. And again, this goes back to training. It's not just menopause training that internal medicine needs. We need to really be educating internal medicine about medical breast and genetics and really helping primary care doctors do better with risk assessment.
Yeah, I love it. So tell me, what's a dense breast? So is it less fatty tissue? Like,
right. So dense breasts, and for everyone. So dense breast is not something you can feel on physical exam.
Good to know.
Women may come in saying that they have fibrocystic breasts. That's not the same as breast density. So they can have lumpy breasts, but that doesn't correlate with breast density. Density you have to have a mammogram to get breast density information. There's 4 categories of breast density: fatty, scattered, heterogeneously dense, and extremely dense. And category C and D, heterogeneously dense and extremely dense, are considered the increased density categories. About 50% almost of women in the United States have dense breasts and fall in those 2 categories. Heterogeneously dense breasts in general, and again, it really correlates with percent of glandular tissue compared to fat in the breast. And it's a scoring that the radiologists do. But heterogeneously dense breasts, obviously there's less glandular tissue compared to fat than extremely dense, has about a 20% relative increased risk for breast cancer. And extremely dense breasts has 2 times or more the increased risk associated with breast cancer. So when I'm talking to primary care doctors or women, the category, if we focus on anything, is to identify those women who really have the extremely dense breasts, because in general, those women, if we do the risk assessment models, will hit the 20% threshold to get enhanced screening with breast MRI. And those are the women we really know that mammographic sensitivity is low, and that those women we should really be finding those women. And the women with extremely dense breasts is about 10 to 15% of the population. So again, smaller than this 50%. And again, it would be perfect if we were doing it perfectly for all 50%. But, I think I'm trying to start small to make an impact. So even just identifying the extremely dense breast women would be a start.
I love it. I think so much, medicine's done so well with like genetics and risk factors, but I think what's happened, what I see, is people being like, genes are destiny, right? And they really kind of throw out the role of exercise, food, not drinking, adipose tissue, body composition in risks for anything, but specifically breast cancer, right? People are like, my family this. And like they throw away, and I got into this, like the role of alcohol in breast cancer because of the estrogen fear, right? People are so afraid of estrogen, and they're not afraid of alcohol at all, which is a class 1 carcinogen associated with 8 different types of cancer. And so that's where I was like, oh, we're afraid of the wrong thing.
And I will tell you, I do that every single day in practice, which is a patient will come in and say, well, I don't want to take hormones because I don't want to do anything that's not natural. And yes, I'm having terrible hot flashes, but I'll never take hormones. But, they're having 2 glasses of wine a day. And P.S., they're also using CBD or TH gummies to manage their hot flashes, which is completely unregulated. And we don't know, really what that's doing long term. And we have great data about the hormones. And I can actually talk to them about the relative increase in risk over what period of time. And again, we could go on and on about differing estrogens and serum activity and all of this kind of stuff. But again, really having to counsel them that the estrogen that the alcohol is a problem. Like if you're not going to take estrogen for your hot flashes because of breast cancer, you really shouldn't be drinking alcohol either, because your risk is increased from that as well.
We have decent data that stopping alcohol decreases the severity of hot flashes as well, right? Doesn't alcohol can make that worse?
There is a little bit of data about that, right? And there, again, women often will note that the severity of their hot flashes and night sweats are worse when they've had more alcohol. So there's tremendous number of reasons not to drink. Never mind that women gain weight at midlife and it's empty calories, and you have to do calorie reduction at midlife because of the loss of lean muscle mass and increase in body fat and decrease in your caloric needs. And alcohol's high calorie. So that's the first thing I talk to my female patients about at midlife. May help your hot flashes be a little better, lowers your breast cancer risk, and you won't gain weight.
And you'll sleep, and it's better for your anxiety.
Yeah.
Also, your skin looks great when you don't drink alcohol. No, I mean, I really got into that.
You can't talk to me about that. You're young. Just wait till you're 60. Your skin doesn't look good anywhere anymore. You're just 60.
I hear you. I hear you. So with your journey through breast cancer and, side effects of treatment, how did you manage or how do you still manage, are you still taking hormone blockers?
Yeah.
Like,
Yeah.
how do you manage the side effects? Because I think women do not understand that there are side effects, that
Yep.
they can do things that can manage them, that it is because of the hormones being blocked. Can you kind of go through that, maybe sharing your journey and then what you offer women?
Yeah, for sure. So, yes, I say every time I lecture now that I live my own patient population. I am a 9-year breast cancer survivor who is taking anti-estrogen therapy still for my breast cancer. I personally am on tamoxifen, didn't tolerate an aromatase inhibitor very well. I have continued horrible vasomotor symptoms and night sweats. I have been on absolutely every non-hormonal option there has been, and my friends and colleagues in the Menopause Society have seen me over the years have all of these ongoing hot flashes at professional conferences and all of my journey with trying all of these things. So I have lots of personal experience with the drugs. And then I also have sexual dysfunction, right? So I'm a menopausal woman on anti-estrogen therapy, tamoxifen with hot flashes and sexual dysfunction and all the other survivorship issues. So I definitely live my patient population and do a lot of things to manage it myself. I have a good doctor as well, but so for my hot flashes, I will tell you I'm on oxybutynin, which is probably one of the less commonly used medications. I've heard you talk a little bit about oxybutynin, and I can tell you have concerns as a urologist about it being an anticholinergic and dementia risk. Again, I think there's data in an older population, and I can tell you it's not that I don't personally have any concern about that. I can tell you for me personally and for many of my breast cancer survivors with very severe symptoms, it has by far been hands down the most effective thing. I have tried to go off it many times, and my husband knows immediately when I'm trying to stop it because within 2 weeks, he says, "Oh my God, you're sweating all night again. You're waking me up." Like I'm waking myself up, but I'm waking him up. And so oxybutynin has been the best thing. And then in terms of, sexual dysfunction, I do a lot of this in practice with my breast cancer survivors as well. I just had a new patient today who's about 2 months out from her bilateral mastectomies on an aromatase inhibitor and having sexual dysfunction. And just went through my whole litany of things that I talk to patients about early on when they're on aromatase inhibitors, which we know causes the most severe sexual dysfunction in patients, about really all of the options and about really starting very proactively in terms of what to do. So really talked with her today about the difference between moisturizers and lubricants. We talked about, dilator, showed her different dilator options that are out there, gave her samples of some things, really proactively talked to her about, really trying to maintain sexual activity now because the aromatase inhibitor, she's going to be on it at least 5 years, right? And the effects of that are quite significant. And so again, I certainly tell my own story and use my personal experience when I'm talking to patients, now about what products and things have worked well for me.
Yeah, I love it. I think I love that she got to you early because when people get to me, it's been
Right.
year 4 of 5, and we're actually having to kind of do some reversal of damage that has been done. I said damage, but we haven't been maintaining the tissues and we've been avoiding sex, right? So you have the whole psychological avoidance thing that you've got built up now.
Yes.
So much. So I love the fact that it's more proactive, and I love that I'm a urologist, so I take care of all the men, right? You do not start a prostate cancer conversation without talking about the effects on erections. And that's just our world, right? And so for me to be like, what do you mean the breast cancer women have to kind of come in suffering before this conversation happens, right? It's it's backwards compared to the men.
I'm working on updating a talk that I'm doing this weekend in Texas about sexual health in breast cancer survivors at a survivorship meeting. And that's exactly right. I mean, the data's terrible in the breast cancer space about the fact that, I mean, even now, even with all of the sexual medicine and menopause kind of coming to the surface and people talking about it, but, and again, on the world of medicine is hard. Oncologists work really hard. They really are taking care of making big, huge clinical decisions for patients. And patients are worried about just being alive, right? And so the conversations about sexual health proactively don't actually happen. The data really is showing that. I think the paper I just looked at was 38% of oncologists mention it before and 15% after treatment has started. And so it's a small number. And we know that women go untreated in the breast cancer space. And I do think that you're much more proactive with the men of talking about this. I mean, I think our approach to men's sexuality and women's sexuality is really different still today.
Yeah.
And I'm sure you would agree with that.
Well, I think that's what makes the female urologists in this space so unique, because we treat both genders. I mean, you're internal medicine, you treat both genders, but we see how the men are treated in regards to hormones and sex and quality of life. And then the gynecologists don't see that. They're not erections first, hormones first, quality of life first. It's a very forward discussion in men. And then it's almost oh, well, you care about your quality of life? Aren't you just happy you're living longer? It's a very backwards. So I think that's why the urologists are the superpowers, to be we're not treating these people the same. They're both in my clinic.
Our Medicare CMS coverage for things doesn't treat men and women the same either, which is the crazy thing too.
Oh, it's crazy.
Certainly I know that, we're all really involved in trying to, again, re-look if there's anything we can do to change package labeling on the vaginal estrogen and kind of make some inroads on.
It's coming. It is coming.
Better coverage.
I think one thing for people to hear is doctors are strapped for time. We've got so much stuff to manage. We don't always bring it up. And really that the confidence, the empowerment to have to come from the individual, to be okay, things you don't need prescriptions for are the non-hormonal vaginal moisturizers and lubricants, the hyaluronic acid ones, whether it's a suppository or it's a liquid. You can do that without involving a doctor, and you can listen to podcasts like this and things where you don't have to get into the doctors to do it. So can you talk about the role of what you can do without needing to see your doctor? Or
right. So to your point, that's exactly right. I mean, I think that there's two things that I'm very passionate about, and it all relates to education, right? It's education of primary care clinicians really in this space about menopause, about breast cancer risk assessment, about sexual medicine, and really trying to bring them into the space of being able to collaborate and treat all these people, these women, because we're not adequately treating these women. The data is very clear: breast cancer survivors and non-breast cancer survivors. And so educating physicians is key, but educating consumers, educating women is really key, because to your point, women need to have tools and language and confidence and the ability to be able to raise questions with their physician when they're not getting care, but also to navigate the huge morass of products, advertising, everything, to try to drill down and find good, reputable products when you and I both know that there's misinformation and disinformation that's out there on the social media that's women are being targeted to as well. And I can tell you, I see a lot of women who, I think in a best case, they've wasted money, and in a worst case, they've been harmed by some of the things that they've purchased or sold or bought to. But specifically to your point in this space, for not just breast cancer survivors, but all women who are transitioning through menopause who may start to notice sexual changes of dryness and pain with sex. Learning about the difference between moisturizers and lubricants, learning about the difference between water-based versus silicone-based, kind of understanding which products contain hyaluronic acid, which products don't, experimenting a little bit with creams or suppositories. One of the big things I do in practice, and I predict you do too, is I actually put women up in a stirrup and get a I get the mirror out. I actually take a Q-tip, they're in stirrups, I have a mirror, I prop them up, I actually show them their own anatomy. I mean, women really don't look, and a lot of times they're just having pain down there, and they take their hand with some cream, they just kind of rub it down there. It doesn't get where it's supposed to go, right? Really showing them how to spread their labia, where they should be applying it in the introitus for the most benefit. And again, there are really good products out there that, again, if we could correctly educate women to start with some of the good over-the-counter products, get some information from your podcast and others, reliable resources, that, again, we can help women and empower them to be better advocates for themselves in this space. Because I think you would agree that one of the reasons that Viagra took off the way it did, and I remember this, right, when it came out, is that men came in. I mean, I think in the beginning it was only going to be urologists that was going to prescribe this, right? But that's not what happened. Men came in droves demanding that their internal medicine, family medicine doctor prescribe this for them because they prioritized sexual function and they demanded it. And I think we need to elevate the voice of women in the same way, to go in and say, okay, these over-the-counter things I've tried now, but they're not working and I need more help. What are my options? And then we need to have trained doctors being able to take care of those patients.
Yeah. Absolutely. I mean, the confidence that I see in women, like how many thanks do I get of like, because of you, I went in and got my vaginal estrogen cream. Because of you, I went in and I got my estrogen patch, because they learn like you can get good facts. You can go in, you can really be an advocate for yourself. And when you see that go well, you're like, ow, how else can I advocate for myself in this world? Like, it is just a superpower. And so I love that. And please tell me, with the new website that the Menopause Society is doing, as far as empowering women to give them the confidence to have the right facts, like what are you excited about that the Menopause Society is doing in that arena?
Let me talk to you about that. So when we were doing our rebranding, we really had to relook at our mission vision. And the reality is, we can't do it all as a small society where we are right now. And so our focus is actually on physician education. And so although we're really working to revamp some of the resources, and we work very hard on educational, consumer-facing resources, but also for clinicians. So I use a lot of these things called Meno notes for putting them in my after-visit summary with patients, right? So they're reputable, easy to read things to do. But in terms of kind of our ability to do wide scale messaging to consumers, I mean, frankly, the way that you do with your podcast and lots of other people do, is we right now don't have the bandwidth to do that, and have really chosen to focus on the physician clinician education as being our primary lane, and hopefully collaborating with all of you younger clinicians to get the good messaging out on the larger scale to women. Because you're right, there's a tremendous need to kind of figure out how to do that so women are getting good information, not disinformation or misinformation.
I love that, because I think if a woman gets empowered and she goes in and she's up against a wall of somebody saying no hormones in this clinic, what good have we done to empower her if she can't, seek somebody who's trained and accepting and willing to try something?
Can you imagine any internal medicine clinic just saying, we don't do men's sexual health. We're a Viagra free zone. I mean, they'd be out of business.
And furthermore, if you're not going to do hormones, you can't do thyroid, you can't do insulin, you can't do no hormones if you're not going to do no hormones. Yeah. But why, why the bias against the sex hormones, I guess, is so, it's still so many people are like, I went to my endocrinologist, they didn't know anything about sex hormones. Shouldn't they? Aren't they the hormone doctor? And it's like, well, I didn't train them. It makes sense.
Even the reproductive endocrinologists in the GYN space, I mean, they clearly get training and they know it, but that's not their bread and butter. I mean, we all know in practice, we really focus our niche. So, I mean, again, this is just another area where it's like the hot potato. Who owns it? No one wants it. No one wants to do menopause and sexual medicine. Nobody owns it. We don't want to do it. It's time consuming. And it's past the hot potato among the specialists, right? And we've got to change that. And it needs loud voices to change it.
I love what you're doing with the Menopause Society. I promise you I will come to one soon.
Please.
Any final words on what's exciting you about this space, or anything else you really want to get across to the listeners?
I mean, I think it's a really exciting time in menopause, sexual medicine, midlife women's health. And again, I am excited about the direction of the science, and the science not just in the women's health space, in all of the precision medicine, genetics, cell-free DNA. I mean, there's amazing, cool science going on right now, which is really, really exciting. And I think the other thing is just the conversation is changing. I mean, thanks to you and thanks to a lot of, your colleagues that are really tremendous voices in the space. And again, I can see kind of a movement, a change is coming. That's all good because, again, I've been doing this a long time and it hasn't been this way. We haven't seen this sea change happening until the last probably 2 years. So kudos to you.
It's very exciting. Like I was doing this menopause advocacy thing in New York, and one of them was like, we need more research. And I finally like grabbed the mic and I'm like, there's research happening. People just don't know about it. Like it's not getting out because people who like to research don't tend to like microphones, right? Like there are different Venn diagrams. And so it's really like, to get out the research, to empower the clinicians, to empower the patients of like, there's cool stuff happening. And if I can at all be the voice of the translator of like, do we know what's happening and let's get it out there? It's so cool.
Well, guess what?
What?
On Thursday, I was invited by Maria Shriver and Hoda and Jenna, and I'm going to be on the Today Show on Thursday. So I'm going to New York too. So hopefully for some women's health consumer education then, which I'm super excited about and super honored to be invited to do. So
it's same with them. Like, they've got the microphone.
They have the microphone. That's right. That's why it's exciting to do it, right? Because they have a reach that the Menopause Society just doesn't, right?
Yeah.
Like, it takes collective voices and it takes, again, empowered, engaged, powerful women to get the message out there and actually have real impact. So yeah, it is exciting, right? Because they reach a lot of women. So
they totally do. And I'm so glad they're having you on because
it's exciting.
Because science-based, like real good facts, like this matters. And the fact that that's getting elevated is so impressive to me.
Thank you.
Thanks for coming on. I want to have you back though, like in a year or so to talk about more. Cause like, to me, I'm like, the data is going to start coming out now on the, like it's going to start coming out.
And with the non-hormonals, I think we'll have lots more data about that and kind of be exciting. And then, at the meeting you heard about, or you were not the meeting, but, E4 S-tetrol is very exciting. The SERMs, there's good stuff coming up the pipeline, and certainly in the sexual medicine space, some newer things as well. So, I do think a year from now we'll have more options, I think, too. So
yeah, I'm here for it. Thank you so much for coming on today.
Thank you. Thank you so much.